Good evening and welcome to the North Carolina Community Engagement Alliance Against COVID-19, our Learn and Share series. Before we get started, I will turn things over to our interpreters.
Thank you. Can you hear me okay? I couldn't hear Patsy there for a minute. Okay.
Oh, yes, I can hear you. Can you hear me now?
Buenas tardes a todos. Como han visto, los organizadores de este evento tienen la firme determinación de facilitar la comunicación bilingüe en la reunión de hoy. Mi nombre es Mojde y mi cointérprete es Megan y estamos representando a la Cooperativa de Justicia del Lenguaje Tilde. Estaremos ofreciendo interpretación simultánea inglés-español, español-inglés. Good afternoon, everybody. As you've seen, the organizers of this event are firmly committed to facilitating bilingual communication in today's meeting. My name is Mojde and my co-interpreter is Megan, and we are representing the Tilde Language Justice Cooperative. We'll be providing English-Spanish and Spanish-English simultaneous interpretation. Si usted se unió a la reunión usando su teléfono, por favor, asegúrese de entrar con el app de Zoom para poder acceder a la función de interpretación. Esta función no está disponible en los Chromebook. If you joined on your phone, please join on your Zoom app so that you can access the interpretation function. But please note that this is not available on Chromebook. Si usted no es bilingüe inglés-español, puede seleccionar su canal de idioma, yendo abajo a la derecha en la pantalla de Zoom, haciendo clic en el globito si usa una computadora o en los tres pintitos si está conectado por teléfono. Seleccione interpretación, luego español y luego picarle en Done o finalizar. If you're not bilingual English-Spanish, you can select your language channel by going to the bottom right-hand corner of your Zoom screen. Click on the globe if you're using a computer or the three dots if you're connected by phone. Click on Interpretation, select English, and then click Done at the end. If you activate this option, if you don't understand Spanish, you activate English, if some participants may speak in Spanish and you would want to hear that interpretation. A few guidelines for creating multilingual spaces, algunas pautas para crear un espacio multilingüe. Please don't speak fast. This happens especially when reading a presentation or excited or nervous or running out of time. And if you're not speaking, please mute yourself. Por favor, no hablen muy rápido. Eso pasa especialmente cuando uno esté leyendo una presentación o emocionada, nerviosa o al tener poco tiempo. Y si no están hablando, por favor, pongan su audio en silencio. Por último, les vamos a recordar que por favor hablen una persona a la vez y en un idioma por oración. Lastly, we remind you to please speak one person at a time and with one language per sentence. Estos espacios se crean con el apoyo de todos. Por favor, comunique cualquier problema por la ventana de chat o habilitando su micrófono. Gracias por crear este espacio multilingüe. We create these spaces with everyone's support, so please communicate any issues by chat or turning on your volume. Thank you for creating this multilingual space.
Thank you. Next slide, please. So tonight, we will talk about kids, variants, and do I really still have to wear this mask? Next slide. For starters, we will have Dr. Lance Okeke, and he will discuss managing COVID-19 risk, even when you're vaccinated. He will be followed by Dr. David Wohl, who will be discussing COVID-19 variants. And last but not least, we will have Dr. Mary Braithway, who will talk to us about back to school, kids, and COVID-19. And then we will conclude our webinar with a live questions and answer session. So please put your questions in the Q&A and we will look forward to answering those this evening. Next slide, please. And I have the pleasure of introducing our panelists for the evening. Dr. Lance Okeke is an assistant professor of medicine in the Division of Infectious Diseases at Duke University. He is an infectious disease specialist and NIH-funded HIV health services researcher. Dr. Okeke spends his clinical time between the Duke Infectious Disease Clinic and Warren Vance Community Health Center in Henderson, North Carolina. His current research efforts focus on developing innovative strategies to optimize chronic disease care among persons with HIV, and he has published over 35 peer-reviewed articles in the field. Since the beginning of the pandemic, Dr. Okeke has taken interest in COVID-19 associated racial disparities, working with other disparities researchers at Duke to better understand the disproportionate effect of COVID-19 on communities of color. He has served as the site principal investigator for the NIH-sponsored ACTIV-2 trial for COVID-19 outpatient therapeutics at Duke. Dr. Okeke is board certified in internal medicine and infectious diseases, and also holds a Master's of Public Health degree in epidemiology from the University of North Carolina, Gillings School of Global Public Health. Next, we have Dr. David Wohl, who is a professor of medicine in the Division of Infectious Diseases at the University of North Carolina. He is co-principal investigator of the Global UNC Infectious Disease Clinical Trials Unit and site leader of its Chapel Hill research site. Dr. Wohl is a clinical scientist with a focus on emergent infectious diseases. He has spent over 20 years leading research into the prevention and treatment of HIV and served 2 terms as a member of the U.S. Department of Health and Human Services Antiretroviral Guidelines Panel. In 2020, he helped lead the UNC clinical and research response to COVID-19. He is a medical director of a large drive-through testing site, as well as 2 COVID-19 vaccination clinics. He serves as vice chair of ACTIV-2, an international AIDS clinical trials group, Operation Warp Speed trial of SARS-CoV-2 therapeutics. He has an active clinical practice at UNC. Next, we have Dr. Mary Braithway, who is a North Carolina native and attended undergrad at University of North Carolina at Chapel Hill. She obtained her master's degree from the UNC School of Public Health within the Department of Maternal and Child Health, and her medical degree from the UNC School of Medicine. Dr. Braithway completed her pediatric residency at Duke Hospital. She worked with adolescents in Raleigh before joining Chapel Hill Pediatrics and Adolescents in 2011. Dr. Braithway is a board member of the Durham County Department of Public Health and has been working with community partners to deliver COVID vaccinations in Durham and surrounding areas. Dr. Braithway lives in Durham with her husband and 3 children who have recently started year-round school and are ready to get their COVID vaccines when they become available to younger children. Thank you very much. And I just would like to welcome our panelists, and I will pass the mic to Dr. Okeke. Next slide, please.
Thank you, Dr. Poston. Next slide, please. So thank you for having me. And I just wanted to use this opportunity to look back at the the science behind the epidemiologic curve of COVID-19. Of course, we are now into the 17th or so month of this pandemic. And there have been two major inflection points that have kind of really affected the trajectory of COVID going forward here in the United States and elsewhere. The first hour represents the date in which the first COVID vaccine got a emergency use authorization for use for persons per priority, that are adults are eligible for the vaccine. And that happened around the December 11th of 2020. Since then, you can actually follow the curve downwards after the vaccines were made available, and a steep curve downwards in terms of number of cases of COVID that occurred. And so it's clear and undeniable that vaccines had a very definitive effect on the number of cases nationwide of COVID-19 infection. Now, of course, with the progress in the case rates around the country, the CDC, for many reasons, decided that because of relatively high vaccination rates, that to start kind of towards a push towards normal, perhaps persons that are vaccinated could go without wearing masks outdoors and indoors. That was announced sometime in late May of 2019, and you can see from the red line what happened soon after those recommendations were issued by the Centers for Disease Control, in that we were going down and all of a sudden we're coming back up. And there are a couple of reasons for that. The first being, of course, the Delta variant, which Dr. Wohl will talk about in detail shortly. But the second is because we never really quite hit the number of the threshold for vaccination that we needed to safely unmask and start to push in earnest back to normal. Next slide, please. So the trends are similar here in North Carolina. You can see on the left that if we say that 70 to 85% of individuals have to be vaccinated to reach start to reach the threshold of herd immunity, the number in North Carolina today is 46% of all persons are fully vaccinated. And so we are well short of the threshold we need in terms of like the proportion of the population vaccinated to start to even look anything close to normal. And with the arrival of the Delta variant, I think unfortunately we're in for this phase of the pandemic much longer than we anticipated and desired. Next slide, please. Now, there is a question, however, about vaccinations. And now that we're hitting about 50% of individuals that are vaccinated nationwide, there's enough new cases of COVID going around the country, and that we're actually starting to see these breakthrough cases in persons who have been vaccinated. They've made the news, and there's a lot of kind of sensationalism around how big of a deal this is that people with COVID that have been vaccinated against COVID are now getting COVID-19, and some are getting sick as well. But to put this in scale, I want you to focus on the bottom number of this chart, in that you see that as of July 19th of this year, so just last week, there were about 1,100 cases of deaths amongst persons that were vaccinated due to SARS-CoV-2 infection. When you compare that to the number just since January 1st, not through the entire pandemic, but just through January 1st, 255,000 mostly amongst persons that were unvaccinated versus really less than 1,000. If you look at the people that were asymptomatic with COVID and at the time they died and actually died for another reason, there is no comparison. The truth is that 99.5% of all people who have died of COVID to date were unvaccinated at the time that they were deceased. And that is the truth. And 97% of persons hospitalized with COVID-19 today are unvaccinated. And so overwhelmingly, although people that are vaccinated do get COVID and do get sick sometimes, it's highly uncommon, and it's even less common for those persons to succumb or get hospitalized as a result of those infections. Next slide. And so the question is, okay, if you don't get that sick from COVID, what can we do to start to mitigate risk so we can prevent infection going forward? A lot of these new infections in the context of breakthrough are due to the Delta variant. And there are precautions that we need to take as a result of the emergence of this Delta variant to start to move forward towards a place where we can feel safe about conducting our everyday lives. So if you're unvaccinated, first of all, of course, it's obvious that we wear a mask always when you're indoors, regardless of setting, regardless of crowd. But of course, people with weakened immune systems, if you're around them, then you stop. But also, you also wear a mask. But also crowded outdoor settings. So when there are lots of people outside, you stop and you wear a mask if you're unvaccinated. And of course, all cases of public transportation as well. Next slide. Now, if you have been exposed to someone with COVID-19 and you're unvaccinated, there is necessity to quarantine for 14 days after your last exposure to the person with COVID-19. But also you have to watch for symptoms and make sure you don't become symptomatic. And then perhaps your local health department will give you guidelines on how you can actually shorten that level, that length of time for quarantine. Next slide. Now, I think this is the question du jour, however, about when to wear a mask. And I think I'll have you apologize in advance that this is a very dynamic situation coming from the CDC, and that the CDC actually released new guidelines of when to mask and who needs to mask when they're indoors, probably within the last 2 hours. And so this is all dynamic. And I think just to synthesize, the basic message is that if you're vaccinated, because of the emergence of the Delta variants, even if you're vaccinated, in most places, it's highly advisable that you actually mask while you're indoors. Places with substantial and high incidence of COVID cases, as we'll define on the next slide, which is essentially most of the Southeast and most of North Carolina, all persons, regardless of vaccination status, should actually wear a mask when they're indoors in public places. Of course, if you're around persons with weakened immune systems, and if you're in public transportation, those are unique settings. But here in North Carolina, for the most part, if you're indoors, you need to mask, even in the case of vaccination, full vaccination. Next slide, please. Now, I showed this because this is an indicator of all the places in red and orange. So counties on the county level across the United States. This is from the COVID tracker at the CDC, and the website was on the last slide. That all the places in red and orange are places based on CDC recommendations that you have to mask when you're indoors, regardless of vaccination status. You can see, if you look at the borders of North Carolina, that includes most of the 100 counties of North Carolina as of today, based on CDC guidelines. If you're indoors, wherever you are, you need to mask. Next slide. Now, there are some benefits of full vaccination, however, and so that if you have been exposed to someone with COVID-19, as of today at least, that if you've been exposed and you're asymptomatic, you actually don't have to quarantine after you've been exposed, unless you have symptoms. So the key is to monitor your symptoms, but if you have that exposure, you can still conduct your normal lives, but of course take common sense precautions to curb the spread. And then if you have symptoms, then you revert back to the quarantine as recommended by local health department and CDC guidelines. Next slide, please. Now, of course, for everyone, best practices are common regardless of vaccination status, including maintaining 6 feet of distance when you're indoors or outdoors, taking note of the ventilation in the places that you go, and if there is poor ventilation, minimizing your exposure to that indoor situation with the poor ventilation. There's some questions on here to consider. Where are the windows? What's the air conditioning like? What's the air circulation like? How crowded is it? Does it feel stuffy? So subjectively, does it feel stuffy? All those things, amongst others, are things to take into consideration when considering ventilation status of wherever you go. Next slide. Of course, these are the common ones, like washing your hands often, covering your cough and sneezes, cleaning high-touch surfaces within your households, and definitely when you're out in public. Paying attention to your body for symptoms, so being vigilant about the changes in how you feel, and looking for specific symptoms of fever, cough, sore throat, nasal congestion, fatigue, and muscle aches. And again, a little bit more subtle, but it's definitely something to look out for. Fatigue, muscle aches, and nausea and diarrhea, as well as GI symptoms associated with COVID. Next slide. And of course, if you have symptoms of COVID, stay home, wear a mask, hydrate, watch for your symptoms, and reach out to your clinician or local urgent care to schedule a test to confirm your diagnosis if you suspect that you have COVID-19. Don't just go there and show up, but actually reach out, schedule an appointment, get tested. Next slide. Of course, if you have any of the trouble symptoms as listed here, you call 911, trouble breathing, chest pain, confusion, drowsiness, blue skin. Next slide. So here are the main takeaway points, and I think there are many. The truth is that cases are on the rise again, unfortunately, primarily driven by the Delta variant, but also driven by the fact that we've fallen well short of required vaccination rates amongst adults to actually start to get to herd immunity. The truth is that vaccinated persons are getting COVID. However, they're not anywhere close to the rates in which you would get the impression of watching the news, but it is possible and you should take precautions. Cases of symptomatic COVID amongst vaccinated persons are uncommon, but they are happening, so you should be aware, take common sense precautions. And in the areas where there is high incidence or substantial incidence of COVID-19, you should mask indoors, regardless of your vaccination status. Everyone should maintain best practices, and so that everything that you've learned over the last 17 months about hand washing, social distancing, and the like, please still maintain regardless of your vaccination status to the best of your ability. And I think above all else, I think you have to start any talk about COVID-19 risk mitigation with the basic truth. Please get vaccinated. This is your best option against getting sick and dying from COVID-19. So I'll stop there. Next slide. And I'll pass it on to Dr. David Wohl to talk about COVID-19 variants.
Thank you, Dr. Okeke. That was fantastic. So let me spend just a few minutes talking about COVID-19 and a word that I don't think many of us had used before COVID-19 pandemic, variants. Next slide. This is, I think, a really helpful illustration that lets you visualize a lot of what we talk about when we talk about SARS-CoV-2, which is the virus that causes COVID-19, and some of its pieces and what it does. And you can see at the top is the actual virus, and those red parts, those spikes, if you will, are the spike protein, and they coat the virus. And that's really important because it's sort of like whiskers on a cat. These are the spikes that protrude from the virus and that the virus uses to interact with its surroundings. So the spike will attach to receptors that are on our cell surface, and it'll use those receptors to gain access to our cell, almost like a lock and a key, with the key being the spike and the receptor being the lock. And what it does is then it takes its blue part, its genes, and inserts it into our cell, and then can replicate inside of our cell with that blueprint for the information of the virus. So this is really important for us all being on the same page about what's going on and what happens when we talk about vaccines, because vaccines produce antibodies that attack the spike protein. If you can coat the spike protein with lots of antibodies, which are like little missiles, then it can't interact with the cell receptor. The lock is blocked because the key is gunked up with all sorts of things on top of it that won't let the key go into the lock. So that's really important. The other important part about this that we think about is that it's the spike protein, which is the target not only for our vaccine antibodies. So the vaccine makes us produce antibodies, which is great. Those help us by circulating. And once the virus comes into our system, we can fight it. We have a jump start on fighting it because we have already our antibodies recognizing this. But even the antibodies that we make if we're not vaccinated will also attack the spike protein. So when the spike protein changes, those antibodies may not recognize the spike protein that's now different than the spike protein that it saw before. So if you've been infected before and now a new version of the spike protein comes along, your antibodies may not really recognize that as well. Even if you're vaccinated, you'll probably do better at recognizing a new version of the spike protein, but maybe not as well as you would of the OG spike protein. So I think that's an important point too. And it's the spike protein that really differentiates the variants. When we talk about changes in the virus, when we talk about the virus mutating or evolving, and we talk about variants, we're talking about changes largely in the spike protein. So when your spike protein changes, you've got a new variant if it changes enough. And it's changed a lot. Next slide. So we'll go through some of the history over time, but now there are a number of different variants of the virus. And I'll go through this really carefully, but just so you understand, this is not a brand new phenomenon. The ancestral strain, if you will, of the virus that came out of Wuhan, China, within a few months of spreading around the world, it changed. And people this time last year were no longer getting infected with that Wuhan strain, but a slightly different strain that maybe had an advantage in spreading from person to person. And we didn't even really report that or talk about it because that's just what viruses do. We didn't think it was such a big deal, but people noticed it and we tracked it, and it happened for months and months and months and didn't change very much. But then more variants started to pop up. And this shows you here when and where some of these newer variants that started to be more concerning popped up. On the left is a virus that we now call Alpha, a variant we call Alpha. And it was first detected in the United Kingdom. Now, it's important to recognize this is where these were detected. We don't know that this is where they originated. And it's not really fair to the United Kingdom or South Africa or Brazil or India to say these are, UK viruses or South African or Brazilian or Indian. This is where they were detected. It could have been somewhere else, but they just didn't detect it. So back in September 2020 in the UK, they noticed that the virus had changed again, and that this virus was predominating. You learned about survival of the fittest in school. This is what's happening in real life. The survival of the fittest, the virus that can do better and outcompete the other variants are the ones that are going to spread. And the advantage that these variants generally have is that they're usually more catchy. They're easier to spread. And the other thing, the reason that is, and we don't talk about it much, is it's not that they're stickier or that they're more ferocious or more resistant to sunlight or air. Probably one of the main reasons is their spike proteins have changed in a way that don't let our natural antibodies fight them very well. And as I'll show you in a second, Delta is like the ultimate variant in that way. Our immune systems, it recognizes it, but not nearly as good as it needs to. And that lets Delta get the leg up, such that these variants produce more virus than they normally would have, because your immune system is not bottling it up and fighting it. So it's a losing battle. The viruses replicate, they make more of themselves, and they stick around longer. That leads to more contagiousness. You'd rather have someone sneeze on you with just one particle of virus than sneeze on you with 10,000 or 100,000 or 1 million particles of virus. It all comes down to inoculum. That's what we call that. Dr. Keki and I, in infectious disease, it's inoculum. In real estate, it's location, location, location. Infectious disease, inoculum, inoculum, inoculum. How much inoculum? That's what really counts. I don't care if there's 1 E. coli on your sponge, you're not getting sick from that. You got 1 million E. coli on your sponge, you've got a problem. So let's go through this again. So Alpha was the UK variant back in September. We talked about it a lot until Beta came along, first detected in South Africa. Then we heard about Gamma, which sort of was scary because Brazil was having a run of it. We were worried that's pretty close to us. Didn't really take off here as much. And then Delta. And Delta spread like wildfire. And Delta is different. Delta is more fit. Delta is more dangerous, and we'll talk about it. Now there's other ones down at the bottom They also have Greek letters, and the Greek letters are supposed to be used instead of the geographic location, so as not to really stigmatize these places. And that makes sense because we didn't talk about it, but iota came from here. And we don't want to call it the USA virus, right? And we don't want to hear about a North Carolina virus, right? So we know how it feels. So we don't want that to happen. Next slide. This gives you a little bit of a picture over time of which variant has come along and gone. And what you can see is Alpha started back in the beginning of 2021, really started to take off. And this is in the US. In other parts of the world, it had already spread. And then you can see over the last few weeks has dropped down dramatically. But the overall shape of this curve, if you ignore the colors, is more and more and more and more. So these are all contributing to, there's an increase in the amount of virus that we're seeing around. It's just the composition, what's making it up is changing. And you can see as Delta and Beta and Gamma started to go down, it's because there was a new kid on the block, and that's Delta. And Delta now has subsumed pretty much everything. In just the last 4 to 5 weeks here at UNC, we sequence all the virus that comes to our lab here in Chapel Hill from swabs of noses from people who got tested, including from other parts of our system, from other parts of the state. And now we're up to more than 93% of the virus that we're sequencing from people's noses is Delta. So the scary part about this is just how quickly this happened. It took a while before Alpha became the Alpha and before Beta became the Alpha virus. And now Delta is the Alpha virus, if you will. And it just took so much less time. Okay, so that gives you a sense. Right now, when we talk about COVID-19, we're talking about Delta in the United States. Next slide. So why is Delta a concern? Okay, that makes sense. It evolved. It's better. It's worse. Or well, what's up with it? Here's the bottom line. There's pretty good data that show that people who get infected with Delta have a lot more virus in their noses and throats than people who've had the previous variants. So again, that means there's more inoculum. More inoculum means you're more infectious. The other thing is that people who have Delta probably shed the virus longer. That means whereas a previous variant, maybe you'd be shedding the virus for 5 days, this may go on for 6 or 7 days. So you have more virus and you're shedding it longer. The current vaccines, and this is really key, they do protect against severe disease from Delta. As Dr. Okeke said, when you look at people, even in countries where there's a lot of Delta, the proportion of people who are getting hospitalized, still very few of them are fully vaccinated people. But again, we know that this can happen, and that's why we talked about all the protections that even vaccinated people need to take. So the vaccines work. They work really well at preventing severe disease and death, even from Delta. But I'll show you data in a second that suggests that they may not protect us as well from just getting infected. And really important point. I read a newspaper headline just yesterday in the Washington Post saying basically the same thing. People can get infected with Delta even if they're vaccinated. And under it, it said, the vaccines turn out not to be perfect. No vaccine that's ever been created is perfect. These vaccines that we're talking about for COVID-19 are highly, highly effective and incredibly safe. And we've learned that from giving it, close to 200 million people here in the United States alone. So huge, huge experience. The other thing is, if you've paid attention up until this point, the whole idea behind the vaccine is to allow you to get infected so your body can respond to the infection, to the virus, and wipe it out. It's not a golden force field that doesn't let the virus get into your nose and throat. The idea is once the virus gets into your nose and throat, i.e. you're infected, your body stomps on it and gets rid of it. So infection is part of the plan with an immunization. It's in case that happens, this is what will happen. You can't blame the smoke alarm for there being smoke. the smoke alarm does what it needs to do once it detects smoke. That's what's happening with the vaccines. So it's not a bummer that somebody gets tested because they're on a baseball team that doesn't have half a brain and half the people aren't getting vaccinated and they're getting tested and somebody's testing positive. Well, of course they're testing positive because they've been coughing and breathing and talking on each other. And one of the baseball players, or 2 or 5, got the virus in their nose. They feel fine, but they're a COVID-19 case. They're infected. So just understand, infection is not necessarily a bad thing. We should really start talking about disease. Who's getting sick? Because the vaccines are protecting people from getting sick remarkably well, even from Delta. Next slide. So why are we talking about this? And I think you know, and Dr. Keki really pointed out nicely, it's because of the surge. And the surges in new cases, the surges in hospitalizations, and even death, they're really the responsible party is Delta. That's the number one thing. The second responsible party is the unvaccinated. And unfortunately, that's true. We have 2 things that have really conspired to the Delta surge. And one of them is Delta, and one of them is the high proportion of people who are not vaccinated. And we've got a lot of Delta and we've got a lot of unvaccinated people. And that's what's causing the surge. If people were vaccinated at a very high rate, we would not be having nearly the size of the surge we're seeing now. And we might not have had a surge at all, I believe. So we're really, we understand exactly what's going on. There's no mystery here. The other thing is we had the example of the United Kingdom right before us. And their playbook is our playbook. They have more people vaccinated. They have more people fully vaccinated. And they had Delta way before we did. And they went through the same thing. And it got worse. And it's still bad there. So we're no different. The only difference was we didn't have Delta yet. Now we do. So there's no mystery here. There's no, you don't need a crystal ball to see what's going to happen. Next slide. So these show a little bit of information about the vaccines and what they do from different studies across the world. And let's just look at the blue line, you know, the electric blue line. This is the Pfizer vaccine. And it's showing in different countries their data about how well they think that this protects against Delta relative to Alpha. Remember, Alpha was the virus that was first detected in the United Kingdom. And you can see in England, they didn't see that much of a decrease in efficacy in protecting against infection on the left. In Israel, they've seen more, and that's curious. They say they have a smaller sample size than they would like. So we don't know about the confidence of those data, but those are worrisome. But good news is from England, Scotland, and Canada, solid line. If you're fully vaccinated, it looks like minimal difference in infection rates. The dotted lines are people who only had 1 dose. You can see they're already starting at a disadvantage. Taking both doses is really important for 2-dose vaccines. The other vaccines that are listed here are the AstraZeneca, which is very common in Scotland and England and the UK, and you can see some data there. We don't have that here. And there's very little data on Moderna from these other countries. They don't use it as much. But what about hospital admission on the right? England, Israel, Canada, hardly any change. These vaccines are working great to prevent those in these countries comparing Delta to Alpha. Next slide. So my takeaways: 1, variants happen and they'll continue to happen. That's why it's good there's a lot of letters in the Greek alphabet, because this is going to keep happening. Viruses evolve. It's natural, just like we evolve, just like anything. Dr. Keke and I work with HIV. HIV evolves, and we're always keeping up with it. This is going to happen too. And we can stop variants if we stop replication. You can't have a mutant baby virus if you're not having baby virus. And so if we shut down replication, if we shut down transmission, then the virus can't change. It needs to mutate and reproduce to change. It reproduces when it spreads from person to person. Delta is now the dominant virus worldwide, here in the US, here in North Carolina, here in Chapel Hill. It is much more infectious, and we didn't talk much about it because it's really still being settled, but we don't know if all the rules that we've developed up to now, 6 feet, wearing a mask, all those things, I think they're helpful and they're going to be really important, but they may not be as effective. So even more, we need it now. So I would say this is not the time to put down the mask. This is the time to really put on the mask. I went into the supermarket today. I will admit I wore 2 masks. Remember the 2 mask days? If we were wearing, some of us, 2 masks back in January, you know, my question is why not now? But I'm just saying we should be wearing masks. We should be protecting ourselves. We should be really aware and mindful that we have a highly infectious virus that is spreading now through our country and our community. It is really important to recognize the vaccines are so essential here. It's our first line of defense in many ways. So vaccinate, vaccinate, vaccinate. If you were on the fence before, now's the time to get vaccinated. If you were waiting for the right moment, it's come. It's going to be the unvaccinated that are going to really get dealt a heavy blow. For the rest of us who are vaccinated, I think COVID-19 will become a nuisance more than anything else. If I get infected, I'll have to be out of work, like Dr. Keke said. That's going to be a pain in the butt. But because I'm vaccinated, I have much less worry that I'm going to be out of work and in the hospital. Nothing's perfect, but it really, really does reduce the odds of that happening. The best defense, again, in addition to vaccination, is masking. And we talked about this a lot. Mask indoors when you're inside, outside of your bubble. So if you're indoors and you're around people not in your immediate bubble, I would wear a mask. That's what I would do. And indoors with people who are in your bubble or people who are fully vaccinated in small groups, I think that's okay not to wear your mask. So I'm going to stop there. And next slide. And have the honor of turning the floor over to Dr. Braithway to talk to us about going back to school and kids and COVID-19.
Thank you, Dr. Wohl and Dr. Okeke, for the excellent talks beforehand that were lead-ins to what I'm going to discuss. They were an excellent backdrop to now what a lot of us are focusing on is how we get kids back to school safely during a pandemic. Next slide. So I will be talking about what the CDC is saying about this, what the American Academy of Pediatrics is saying, also what North Carolina is recommending about kids and school. Next slide, please. So the AAP says that we should take into consideration that during the last more than a year that we have been living through this pandemic, remote learning has been very difficult for children. It has highlighted inequities in education, and it has exacerbated the mental health crisis that was already in existence, already present. It's just been amplified during this time that many children are isolated and away from their peers, away from in-person education. So we must focus on keeping kids safe, of course, and we also need to keep in mind that as we think about kids going back to school, that not all students will have the opportunity to be eligible to be vaccinated for the start of the school year. When we follow guidance from the Centers for Disease Control, the World Health Organization, and the United Nations International Children's Emergency Fund, opening schools does not significantly increase the community transmission of COVID. It's important for us to recognize that the transmission rates are low when proper prevention measures are used. And it's also important for us to realize and know, I think many of us know this, that the benefits of in-person school outweigh the risk in almost all circumstances for children at this time. Next slide, please. So there are many benefits to in-person school. Among those, of course, is academic instruction. It's very difficult, I can speak from personal experience, to try and work with children, young children, through the computer as they learn. Their social and emotional skills are very, they learn by working with each other, and they learn these skills by playing together and learning together. Safety is something that they gain in schools. They're supervised. They have reliable nutrition. They have access Many of them need therapies, and physical occupational speech therapy can be offered at school. Also, through school, they can access mental health services and health services such as health, hearing, vision screenings, and asthma education. They also have opportunities for physical education and activity, and appropriate supervision allows parents to actually go to work. Next slide, please. I mentioned this before. I'm putting the school bus there for just a visual aid, but it's important to know that thus far, we have not seen evidence that school transmission, it does not drive the spread of COVID. Kids being in school does not drive the spread of COVID. However, there are positive cases that occur at schools, and that does reflect the community transmission. If community transmission is low, then the rates of COVID in school-age children will be low. And conversely, if community spread is high, then there will be more positive cases among school-age children. Children under the age of 10 thus far are not showing us that they are the ones who are getting very sick from COVID. They are, from all the studies that we've seen thus far, and though more are needed, we're seeing that they are less likely to get infected, less likely to test positive, less likely to be the spreaders of the infection to date, and more studies are needed. Children over the age of 10, especially over the age of 12, tend to spread COVID similarly to adults. And the symptoms in children can be ranging from non-existent, or they may be very similar to adults, but they generally are milder. Some often have no symptoms at all. It is critical to limit community spread of COVID in order to ensure that schools can remain open and safe for students. Again, if the community rates are high, then it may be very difficult for us to keep kids in school. Next slide, please. So I just wanted to bring this slide to you to show you that North Carolina has tried diligently to increase access to vaccines. They have a Take Your Shot site that's available to find your vaccine of choice and a site to go get your vaccine. They try to make vaccines, North Carolina's tried to make vaccines readily available, and now are even offering, between a lottery and cash cards, payments for getting vaccines. The AAP, the CDC, and North Carolina all agree that all eligible individuals should receive the COVID vaccine. Everyone 12 and over should receive a COVID vaccine, as long as they don't have contraindications. If there is a question, they should talk to their doctor. And as Dr. Wohl and Okeke have said, COVID-19 vaccinations are very effective and very safe. And we clearly see in one of the slides that Dr. Okeke showed that community spread rates are lower when people are vaccinated. Next slide, please. So the AAP and the CDC and the governor of North Carolina have said that masking is important for kids going back to school, but their recommendations slightly vary. So the AAP, as of July 18th, recommends universal masking for persons greater than 2 years old in school right now. At this time, universal masking, regardless of vaccination status. And as Dr. Okeke said, the CDC has made a change to this guidance. So my statement was from July 9th, and he has given an update to that. So you can disregard my bullet point here. The governor of North Carolina, I am hopeful, will change this guidance, but did announce on July 21st that masks should be required indoors for all students and staff in elementary and middle schools. And in high schools, unvaccinated students and personnel should wear masks indoors at all times. That left open the option for vaccinated students and personnel to not wear masks, but we're very hopeful that this guidance will change very soon. Next slide, please. So to promote vaccinations, and wear masks are the top 2 prevention strategies for keeping our kids in school. They need to wear these masks consistently and correctly, and vaccinations should be administered and accepted by persons who are over 12 for those who are eligible to receive the vaccines. There's so many children who are not eligible just yet to receive vaccines. And so in order to protect them, it is best for masking to be implemented universally and for persons who are eligible to get the vaccine. Physical distancing of 3 feet is being utilized in school. 6 feet was initially recommended, but they did decrease that distance so that more children can be in school. And that seems to be going well in most places. Screening and testing is also important. This is a multi-pronged approach. It's not the only thing that we should do, but screening and testing is an important layered aspect of protecting kids, making sure that we isolate cases, cluster them, and make sure that outbreaks are limited. Outdoor time is helpful. Kids can have unmasked time outdoors. Ventilation, well-ventilated areas are extremely important. Hand washing is also key. And making sure that children and staff stay home when they're sick and get tested is essential to containing spread. Also, contact tracing is important, and cleaning and disinfection. Next slide, please. So my takeaways are really quite simple. Students benefit from in-person learning. Study after study, evaluation after evaluation proves that from all over the country. School transmission is not driving the pandemic. That is clear. We know that kids can go to school safely and not drive the spread of COVID if students are protected by masking, by the multi-pronged layered approach of cleaning, good ventilation, if they have appropriate distancing and hand washing and contact tracing. Again, vaccinations are the lead public health strategy to end the pandemic and keep these kids safe. And the AAP, CDC, and North Carolina schooling recommendations have recently been updated, have some variation, but all promote in-person learning, vaccinations, and masks indoors. Thank you.
Well, thank you. I would like to thank all of our panelists for such a great presentation of this information. It's been very helpful. And I think one of the main things we definitely know is that we need to wear our masks. So I want to hope that everyone continues to wear that mask. That is extremely important. We have a question, and the first question is actually for Dr. Braithway. Dr. Braithway, what are the numbers for multi-system inflammatory syndrome in children? A participant just shared that there was a death in Charlotte last month, and just wanted to get your input on this in children.
Thank you. I am not certain of the exact number of children who actually have had MIS-C. To date, it does appear that we've had in the range of deaths of about 2,700 nationwide. And so the number of kids who have had the non-lethal MIS-C, or it's not usually lethal, is higher than that. But the number of people who died is around 2,700.
Okay, thank you very much for that. Another question, Dr. Wohl, can you tell us, as you talked a lot about the Delta variant, how does the Delta variant really change as we think about social distancing? Do you have any recommendations as to how we should, physically distance ourselves?
It's a really good question, Dr. Paulson. And I think we could wait for the data to tell us to do something different, or we could maybe extrapolate, connect the dots from what we've learned before. So for me, I would say anything we knew about the previous variants and why we needed to be in well-ventilated spaces, why we needed to separate our faces from other people's faces, I would just extend that. I think it's true, as Dr. Braithway showed in school with the previous variants, we really didn't see much transmission from small children to small children. With Delta, we don't know that for sure. And that's why I'm excited about the CDC agreeing with the American Academy of Pediatrics that everyone in a school, just like in a prison, just like in a hospital, just like in a nursing facility or public transportation, should be masked. It's a physical barrier that works. So I would be just like we were before when we were really cautious, plus a little bit more caution. That's what I would recommend we do.
Thank you. Another question, Dr. Braithway, as you are a pediatrician, and I'm sure you talk to concerned parents all day long, what do you tell parents in terms of like sending their children back with the Delta variant being very prevalent, but their children aren't of age to receive the vaccine? What advice do you give them?
That's a great question. I do hear that often too, and heard it yesterday. Many parents are concerned about their children's ability to learn at home. And some kids learn fine at home, but many kids have not done well being remote. We know that it is a personal decision. A parent has to decide for themselves the benefit and that there is some risk of going back to school. But if the schools are following the CDC and AAP guidelines of universal masking indoors and hand washing and allowing the kids to be socially distanced, then I feel comfortable saying that kids can be at school, but it also depends on the level of risk that the family has for severe COVID if they do get a positive case. And hopefully, I encourage the parents to actually get vaccinated, make sure everyone gets vaccinated who's eligible.
Okay, so that's what I was going to actually ask as a follow-up. So when you said if family members within that home, if they are at risk, so if they have any underlying health conditions, if they're, in their immune system is compromised, then that in itself, like you said, definitely to suggest that vaccination for those members is important, but then to really understand that risk for your own family.
Absolutely. Rather than keep the kids home, I would recommend that they vaccinate everyone who is eligible to be vaccinated.
Okay, great. Thank you. Now, as a follow-up, an attendee has a question. So what would it look like if a child or a staff member in class tests positive? What would quarantine look like? And like for the remainder of the class, how would that look?
That's a great question, and I do think it depends on the rules at the school. So that will have to be determined by the leadership at the school. Many times, and Dr. Wohl said this, that or I think maybe Dr. Okeke did, that we don't have to necessarily quarantine if we have a positive exposure, if we have no symptoms. So we'll see if the schools will stick with that, or if they'll tell children not to come if they have an exposure. They may close the whole class. I'm not sure. That is determined by the school.
Okay. Thank you for that. As we are kind of just talking again about the importance of really encouraging everyone to get vaccinated, can all three of you or any one of you tell us, how would you really convince a family member to get vaccinated? I know it's difficult sometimes even for me to try to convince others the importance of that. So what would you use, especially if they're not really confident in the science?
Okay, I can take that, Dr. Poston. I think back at my parents and what I did to convince them back in January to get vaccinated. And back then, we had enough data to show the clear divergence between outcomes in persons that got vaccinated and persons that were unvaccinated. And you think about it and you say, well, I mean, if this vaccine can cut your risk potentially of the ultimate outcome, which is death from this virus that's spreading and going to be continue to spread, unfortunately, for the foreseeable future, if it can cut your risk by 250 times, potentially, of death, then I mean, what is the question here? You know, I think that, I mean, and I look back as well, and it's sobering. I mean, we don't like to get too deep in the data because people are kind of tired of that now. But there's 600,000 plus Americans that wish they would have even a chance at any of these vaccines that are no longer with us, and we can never get past that fact. And then I also tell them about the fact that think about life before the pandemic. Think about life before the pandemic and the fact that if you get the vaccine, and from the case of close to 200 million Americans being closely vaccinated, and all the potential side effects out there that are very, very few and far between, compare that to all the people that have gotten COVID and that died of COVID, and also look at the fact that you can go back to life as it was before the pandemic. And if you get COVID, it might be inconvenient, like Dr. Wohl was saying, but it's essentially perhaps no worse, not that much worse than the flu. You can move on with life on your own end if you just get vaccinated. And so think about that threshold that you cross once you get there, once you get the vaccine, of reverting back. Of course, society won't revert back to that, but at least for your own personal risk, having that peace of mind that the likelihood of you succumbing to COVID essentially drops through the floor. I think that's how I convince my parents, a lot of my patients, basically, that it's a simple thing. And of course, the fact that I am an infectious disease specialist like Dr. Wohl, and I'm sure Dr. Braithway has been vaccinated as well, and we've all gotten it. And clearly, we're not dumb and naive to some conspiracy out there that we've missed. We're very aware of the data, as we've demonstrated today, and we've all got vaccinated, and we're still here 6, 7, 8, 9 months after the fact, as healthy as we were back when we got vaccinated. So that's how I approach it.
All right. Well, thank you all very much. We are at time. I'm sure we could continue talking about this, but I just would like to thank you for being here with us, and like to thank our attendees as well for taking time out of your schedule to learn a little bit more about COVID and what you can do to protect yourselves as well as your family. So everyone take care and be safe, and we'll see you next time. Thank you.
Thank you.